What if everything you've been told about your joint pain was a choice? A choice between comfortable ignorance or disruptive truth. We've all heard the same old, same old. You have arthritis. It's a wear and tear condition. Take these NSAIDs, get a steroid shot, and come back when you're ready for a metal knee, also known as a joint replacement. That, my friends, is the blue pill. It's a model focused on managing decline, not reversing it. But today, we're taking the red pill. In today's episode, I'm joined by Dr. Joseph Albano, the founder of Albano Clinic in Salt Lake City, Utah, and a true veteran in both medicine and service. Dr. Albano has been a leader in regenerative medicine for nearly 2 decades. Today, we're going to dismantle the bone-on-bone myth. We're going to discuss why things like cortisone and statins might actually be destroying your joints. And we're going to explore what Dr. Albano calls Wolverine healing. We're going to talk regenerative injections and how we can stack peptides, hormones, and nutrition to not just patch an injury, but actually regenerate tissue. So if you're tired of being told to just rest or wait it out, this episode's for you. Let's get to it. All right, Joe, welcome to the show.
Hey, thanks for having me here, Greg. Appreciate it.
No, man, we didn't talk about this off camera, but how I found you is I was actually, I didn't go, unfortunately, but there was a conference in San Diego with WorldLink, and you gave a presentation on regenerative medicine. I was like, oh, this is right up my alley right here. And it's always good when, what I like is you were talking. I was like, oh, I know that. I do that too. This is great. I'm not out here on an island by myself.
Yeah.
And it was great to see that. And we're going to really dive into these things here, man. But I really want to start with a little bit of your background, man. So you were a flight surgeon in the Air Force.
Yeah. So before we even get to that, Greg, go back, because I was looking at the stuff you sent me and you're talking about the webinar or you're talking about the slides. I'm like, shoot, did we give him this stuff? Oh, he must have been at the WorldLink thing or seen it. So like, yeah, good,
that's right.
Nice. So we do have that in common. And I had a look at your website too. I'm like, who's this Greg guy? I don't know Greg, but you're kind of cool guy. We'll get into that too, seeing the stuff you're doing.
Yeah. No, man, I love this part of medicine and how we're really getting to impact people. And I love having these conversations with other practitioners that are not only like-minded, but actually have been doing this for a while. And because it's to me, I spoke at a conference this weekend. I was like, well, the best educator is your patients, right?
Yeah.
You learn. And I told the guys I was like, man, you guys are going to learn more from your patients than I can ever teach you.
Yeah.
And I think in regenerative medicine, that is how I've been learning the most. It's like, oh, this should work. Oh, this didn't work. Why didn't this work? And then you really start diving into it, and then you start learning more, and then you see that case again, and we continue to evolve in our practices, right? So I want to, speaking of that, I'm glad, a great segue, man, because I really want to get into some of the things you were talking about at that conference.
Well, I'll answer your first question though too, because we have that in common as well, as we found out off screen. So I didn't want to be a doctor. I wanted to be a fighter pilot, but my eyes were too bad. So doctor is plan B here. And then I figured out that they would give you a scholarship if you got it, and you could be a flight surgeon and you could jump into jets. I'm like, oh man, I want to sign up for that. And so I was fortunate enough to get the scholarship. And I remember it was a 7-page contract, and it says, we're going to do all these things for you. And then the last paragraph said, yeah, you remember all that stuff we told you we were going to do? We'll do whatever we want with you. And I'm like, but wait, you'll give me a chance to fly in jets? I'm signing that thing. And so that's what I did. So then I was a flight surgeon in the Air Force. They paid for med school, and I was active duty and traveled all over the place, wound up in Korea and then Utah, and then went into the reserves after that, because those are the healthiest guys on the planet, as you know. They don't get hurt a lot, so it's kind of boring being the doctor. So being a reservist was great because I got to do the flight surgeon stuff and fly and take care of the guys, still deploying to different places, and then learning sports medicine, and then eventually regen stuff. But it was the best of both worlds, and I'm sure you feel the same way too. Like, I'm so glad I was in the military. It was awesome. The people were so good. The men, the women, like we talked about, they were the best. I miss that. I miss flying, but you know what? It hurts a lot to pull a lot of G's and sustain them. So probably I'm not doing it at this age, but it was fun at the time.
No, and we were talking off camera, man, that is And people will ask me occasionally, like, do you miss the Navy? And I'm like, well, I miss the people.
Yeah.
I miss the relationships. I miss the camaraderie. I miss just that. I don't think there's another organization where people truly have your back. When they say, people say, I have your back, they really have your back. And that you cannot, there's something about that, man, that I've had a chance to work in a lot of different organizations, be a lot of different programs, and nothing really even comes close to that, like at all.
Yeah. It's so awesome. And the guys who came before us too, and women, guys and women, like you look at, the World War II guys, well, there's not many of those around anymore because it was so long ago. But those guys were awesome. I remember talking to them in my training days at the VA and just meeting them. And then some of the Vietnam guys are still around now too. And those guys are incredible. I just love talking to them. So such great attitudes on life, and just service before self really is what it was.
Indeed. And if I didn't tell you, man, thank you for your service too.
Thank you.
Still at one point I had been at one point I was like, man, I've been in the military longer than I've been alive.
I remember when I got to that point too. Like, whoa, that's turning point.
Yeah, it's time. It is now time.
Well, you got to grow your hair out afterwards. I didn't do that, so maybe I can start to do it.
That was the first order of business. First order of business. Like, I need a beard and I need all the hair I can get. was the way I went about it. So I want to start with this, man, because how I connected with you is, again, we're talking about the World Link Medical Conference, and the lecture I saw of yours, it started with this really cool reference to The Matrix, one of my favorite movies of all time, by the way.
So good.
And really looking at not only patients, but also practitioners to choose between the red pill and the blue pill. So in the context of joint pain and arthritis and regenerative medicine, what is the blue pill that conventional medicine usually offers patients?
Yeah, the blue pill is just traditional medicine is what it is. And so what does that look like in terms of what we usually get? So kill the pain is the first thing, right? My knee hurts me, doc. So, all right, here, take these pills. Or even before they get to us, they're taking acetaminophen, some type of NSAIDs, ibuprofen, Aleve, etc., like that. So they're doing all of those things. And then they might go to the chiropractor and get some relief. But then they get to injections when they're coming to see us. Oh, go back a step. Yeah, there's like acupuncturists in there as well. And then they get to see us, and traditional, and I'm going to call it the sick medicine model instead of the healthy and preventive medicine model. But in that model, you're going to get steroids. And what do the steroids do? They damage the cartilage and make things worse. Although you might get some temporary relief, but it's just not a good fix at all, because it's not a fix. It makes things worse. So that's traditionally what you'll get, but then it's even worse than that, because every time you do the steroids, it makes the cartilage break down even more. So it makes the arthritis worse, can make the pain worse. And then you're leading down this path of a total knee replacement. And it's just not good. And then we're going to talk later, but is that the best path? Most likely not.
And that's really fascinating with that, because when it comes to, we're going to really do a lot of the talk today is on arthritis, because in general, that's what leads a lot of people towards the surgeries and the replacements, and it's so common. But this has always driven me nuts. And once I got smarter about it, is that in general, speaking of blue pill, it's like, hey, arthritis is this wear and tear thing. It's a part of normal aging. And the minute I thought about that, if that was the case, then everyone on this planet should have arthritis in their feet and their hands, because we walk and we write and we do things with our hands, and maybe our neck, because we use that all the time. Like every joint in the body would have that, but that's not the case. And then as we learn more about it and we learn about the pathology, it really becomes evident that arthritis is this inflammatory, immune mediated disease. It's all about inflammation. And then when you think about this, and you talked about steroids, how do we treat arthritis? Usually after the, lose weight, PT, everything that's being offered is anti-inflammatory. Everything. All roads lead to inflammation. So if that's the case, why has that been this big misconception in medicine, and why isn't that really focused on more, from your opinion?
Yeah, I think it's just the way we were trained, right? So you're an ND, and I'm trained in the traditional MD allopathic model, and we are trained like this, as you kind of know. This is what you do. You stay in your lane. You don't do any of this crazy stuff over here. Like, oh wait, how about what we put in our mouths, talking about inflammation. So, you know how many lectures and hours I got on nutrition training in 4 years of med school, 3 years of residency, 1 year of fellowship? 1 hour. I got 1 hour of that. That's just wrong, looking at it from that way. So you're right. It's all about inflammation and the inflammatory pathways. And there's a great study that I read years ago. I can't quote the name of the study, but I remember it because it was looking at this too. I used to run marathons and ultra marathons. And you would think, like you're saying, if it's wear and tear, you're going to have breakdown if you're running these thousands of miles every year. But what this study found, and I think it was about 25,000 people in California, and they followed runners long term over like 20 something years. And what they found was that the running did not cause the problems, but if they had a problem and they kept running, then that made things worse. So there was more chondral breakdown that way. And I live in Utah. We live in the land of ACL tears with all the skiing here. And what we see is once you tear the ACL, what happens is, the bones twist. If you look at MRIs, you can get bone marrow edema in there, meniscal tears, in addition to the ACL tear and the mechanical instability. But what it does is it sets off right from that moment it happens, this inflammatory pathway in the knee, and the synovium just makes all these inflammatory cytokines that are in there. And those are the bad guys that then cause a breakdown of the chondral cartilage in there. And it just keeps going. And we still don't know how to, quote, fix that or cure it, but it keeps going. And so you're right. It's all about inflammation in one way or another. That's like mechanical. Then the food part, you talk about that too. And at that conference, there were two great lectures on, looking at glucose spikes and our metabolism and mechanisms of that. And I'm not in more agreement with that. It's unbelievable. So what we put in our mouths really matters. And it's not just simple sugars too, but it's the complex ones as well. Like, I'm Italian. What do we eat? Pasta. We eat tons of pasta, and that's what I did growing up. And that doesn't mean it's the right thing to do, but that's pretty inflammatory on our bodies too. So anything that causes more inflammation is going to make things worse. So you're right. It's all about inflammation.
Yep. That's usually one of the first things. I tell my patients when they're in pain is, all right, let's talk about what you're eating. And we start with eliminate. And I say this is probably going to be like broken record for people that have heard this podcast before. Is like, all right, what do you start? Okay, well, you get rid of 6 or 7 common offenders of increasing or spiking inflammation. And it's usually, and I'm like, brace yourself. This is not going to be fun. I am not about to tell you this to make you feel good.
Yeah.
And it's like, well, what are we talking about here? We're talking about sugar. We're talking about dairy.
Yep.
We're talking about gluten for most people. We're talking about processed food. We're talking about fried foods. We're talking about alcohol.
Oh, yeah.
And I was like, any other fun I can take away, right?
Yeah.
But because these foods will, they kind of stimulate or exacerbate these inflammatory processes. They increase inflammation in the gut, and it just affects everything. So it's a starting point.
Yeah.
Right. And not that avoiding these things is going to cure arthritis, but it can actually help your body start to put the fire out.
Yeah. And it's about little baby steps, I think. You take this step and it does this, then the next one, it's all additive that way.
Mm-hmm.
So food really matters. And again, I was taught none of that. And that's the hard conversation with our patients. So in a traditional orthopedic office or any allopathic office, you have 7 minutes with a patient. Like, you can't tell anybody anything in 7 minutes, let alone figure out what's going on and do a physical exam. So all you get is eat less, walk more, see ya. Like that doesn't do it. And even if you go through, like you're starting to do, I'm sure you go through more than that with your patients, but you start to do that with them and they're like, yeah, I ain't doing that. So now you gotta make them understand the whys and help them be able to do that too.
Yeah. I always have that conversation right after that. I have to be a realist. I've learned to be a realist. It's like, all right, here you go. Now we're at the negotiating. Which one can you stop first?
Yeah.
So,
well, here's what I found, Greg. I don't know if you've done this too, though. So I've not had a problem being overweight my entire life. So thank you, God, for giving me these genes and ability and desire to exercise. But what I've done 2 times in my life now for 6 weeks, what I did was really, 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 really low carb diet. Kind of like a Daniel diet, as they call it, like in the Bible. Daniel was taken to Babylon, and what he did was they wanted to fatten him up and give him all this great food that was not good for a Jewish boy. And he's like, yeah, I kind of really don't want to eat that stuff. How about I eat some vegetables and things like this? And he convinces them to let him do it. So my translation of that is, minimal carbs. So again, no alcohol, no complex carbs, no simple carbs. And it's a little bit hard at first when you're used to doing these things, but after a week or so, you just do it. And it's pretty hard to stay on that just because all this food is available. But after the 6 weeks, you kind of change your habits. You're like, I don't want that cookie that grandma brought over here. Like, it looks really good, but I just eat it. So it changes things. Yeah.
Oh, yeah. Except now grandma's mad at you because you didn't eat the
Oh, my kids would eat them, so she wouldn't mind. She's like, that's okay. They'll eat them.
Yeah, they got it. They got about 30 years or so before they can't have these cookies anymore. So I want to circle back to cartilage because in that presentation, you referenced a study where the researchers probed the knee without anesthesia. And from that and looking at the data and even with the physiology, turns out the cartilage itself doesn't have nerve endings.
Yeah.
But the synovium that you mentioned and the fat pad, they can cause an excruciating level of pain. So if the cartilage isn't what's actually hurting people, why are we so obsessed with cartilage loss in x-rays?
Maybe answer it directly first and go into the background of it. So why are we so obsessed with this? Yeah, that's a great question. Why are we obsessed with it? Actually, no, I'm going to go the other way around. I'm going to background and then answer the question. So the study you're alluding to, this is an awesome study. I love this study. So it was done by this orthopedic surgeon, Scott Nye. And basically, for everybody listening who's not familiar with this, basically what happened was he goes to his buddy, orthopedic surgeon, and goes, hey, I got an idea. Let's do this study. What we're going to do here now is you're going to scope my knee and you're going to touch all these things. And oh, wait, you're not going to anesthetize me. I'm going to tell you how it feels and we'll figure out what's going on. So that's how one way we know some of the data you just said, that the synovium and fat pad is very sensitive. So basically he was going around, his buddy was touching him, and the fat pad and synovium, he's jumping off the table because it's hurting him so much. And I gotta read the quote to you like I did for the lecture too, because it's so funny. Because in the actual paper, he describes this in a medical way, and I didn't think it could be funny if you're reading a journal article, but it is. So here's how he describes that when they touched these painful parts. He goes, penetration of the unanesthetized anterior synovium and fat pad region during the initial exam of the right knee produced severe pain that elicited involuntary verbal exclamations from the subject and nearly resulted in cessation of the study. So basically he's saying, WTF, man, I'm done. You're not touching anything anymore. So I thought that was kind of funny. But that's one way we can see what's going on. So, if you're touching the chondral cartilage, back to your question, it doesn't hurt when you're touching it, not significantly anyway, because there's no nerve endings in there. But we get, I think my interpretation of this is we get concerned about that in the traditional sick medicine model, the blue pill model. We get concerned because we can do something about it surgically. You could go in and you could shave the cartilage in there and you can bill for these procedures and the hospital makes money and everybody makes money. Patient goes out. Usually they feel actually better when they leave from that procedure because what's going on is, if you've seen knee scopes, what happens is, you put a portal in here, another portal over here, and they just dump fluid in here and it comes out over here. So you're getting like the best power wash ever. So you're getting rid of tons of those inflammatory cytokines in there. And that's what's making them feel better, not necessarily you're trimming up the cartilage. oh wait, the trimming up the cartilage is bad because now you have less shock absorber. So you're going to have more arthritis and more likely to get knee replacement down the road. So I think we're focused on the wrong thing with the chondral cartilage, but it's the way traditional sick medicine, blue pill medicine goes.
So if that person, and this is, that's really thing as you were talking, and eventually you will get that patient, or we'll see that patient who is quote unquote bone on bone. There is no, it's all gone. The cartilage is gone. Once they get to that point, and we're going to talk injections and the hierarchy in which we look at that, when they get to that point, is it just game over? Is it just like, look, there's nothing I can inject in there that's going to help you out at this point? Or is there hope with everything we have advanced with over the last 20, 30 years or so?
Yeah, let's answer that with this story. This is a common patient story. So somebody comes in and they have, right knee has bone-on-bone arthritis and the left knee is not. So right knee doesn't hurt. The left knee hurts a lot in there. But wait a second, this one's bone-on-bone. I thought that was like the bad thing. Well, you go back to the study with Scott Dye, what's causing the pain? Inflammatory proteins irritating the synovium and the fat pad in there. So it really doesn't matter how bad the arthritis is in here though. And we see this all the time. Somebody will come in and we'll look at the x-rays, the bone on bone side. And I go, oh yeah, that's the one that's got to hurt. No, it's the other side, doc. This one doesn't. We get the x-rays right. Are they right and left? Are they backwards? No, it's right. So commonly the more severe radiographic side doesn't hurt as much. We think it should, but it doesn't. And it goes back to inflammation. It really does.
Okay.
So
this is fun.
Things to do though, then about that. So then that changes the answer there. So if it's bone on bone, every surgeon in the world would go, yeah, we can do that. And they can. Like, that's not a question of can we do it or should we do it? It's like, when do you want to get on the schedule? And then we'll talk about, is that the right answer in the long run too? But so back to your question of, can you do anything about it? The answer is yeah. You can do some things about it. And again, it goes back to the inflammatory proteins in the knee. And you can do a bunch of things. And there's, like we were talking about in that lecture, great studies by this guy, Philippe Hernigo. He's an orthopedic surgeon out of Paris. And he's unbelievable, this guy. He is the great grandfather of this field. And I started doing regenerative orthopedics in 2007. And I think I'm an old guy in this, but oh no, not compared to him. He started in the 90s or maybe even late 80s. But he's got papers from the 90s. So he's unbelievable. And he's done a lot of studies comparing orthopedic surgery, traditional things like knee replacement, hip replacement, to bone marrow, intra-articular or intraosseous into the bone. And there's great 15-year data. So, right, 15 years. Who does 15-year studies? Like, are you kidding me? One is pretty good. 15 years? Better listen to what this guy finds. So, yeah, it's got things you can do.
Okay. And I think that's key for a lot of listeners, just because you get that radiology report and you see that and you're like, oh, like you said, and you talk to your orthopedic, surgeon, or, even a sports med doc, and they're like, oh, well, look, this is where you are. It's like, when you get on the schedule, it's time for a new joint, and that could lead to other things. But the other thing I want to talk about before we get into injections, because a lot of times when people have that x-ray and they're in pain with it, the x-ray will show osteophytes or bone spurs. And so there was this, I can't remember where I read it, man, or there's this theory of how do bone spurs occur if it's not like you damage like you have some impact to it. And there was a theory that I read, and this might be total BS, man. Hopefully you can clear it up for me, is that sometimes the bone spurs will occur. The body is trying to almost stabilize itself. So it's basically kind of creating this spur where, like, and I was like, this sounds like BS, right? And, and it's like, but is there any merit to that? Are the spurs occurring as almost like, okay, I'm going to spur off, and then the tendons can it was almost like this bridge spanning kind of thing. And I thought, this doesn't sound exactly right. Yeah. Is there any merit to that, or bone spurs just happening because there's so much inflammation in there that this just breaks from a lack of strength?
Yeah, I think it's partly right. So the way I think of this is, it's pressure, right? So again, if you have the cartilage that's this thick and now it's this thick, so you don't have this much shock absorption anymore. Now you got this much. So what your body's trying to do is spread out the force, right? If you have, 100 units of force over here and now it's less than that, instead of say now it's can only take half of that, you need to spread out the surface area. So I forget my physics, what the formula for that is, but you want to spread that force out over a bigger area. And that's our body trying to spread it out by making these bone spurs in there and going, hey, come on, this is not right. We need to have more surface area because then there's going to be less force per unit area. That's the way I think about it.
Okay. All right.
So
that went better than I thought it was going to go. So all right, this podcast is over. What are you talking about? So I want to start getting into some of the regenerative injections, right? Yeah. Because this is where I had no idea before I went to med school that this was even a thing. I'd heard about PRP kind of in the mid 2000s where the athletes were going all the way to Germany for it. It was like, oh my God, Kobe and these athletes went over to get PRP and now they're playing again. And then I get to med school and you realize prolotherapy is almost ancient. And then you start learning about, and then the rise of the biologics, right? Where it became, there was amniotic fluid and then there was Wharton's jelly and then all the way up to stem cell. Now, when you have that patient that comes in with an arthritic joint and they're in front of you, doc, it hurts, I've got this x-ray, I've got this MRI. And now, especially for you doing this for 18 years now, coming up on 19 years, you got this Batman tool belt where you have all these injections at your disposal. How are you making that decision, or how do you kind of process the hierarchy, if you will, of what injection therapy that you want to use?
Yeah, that's a good way to put it. I like that, Greg. I'm going to have to use that. I'm going to steal it from you, my Batman tool belt. So it is, right? You have a Phillips head screwdriver, you got a flathead screwdriver, you got the hex one. There's all these different tools, and that's a pretty good analogy because if you have a hammer, man, everything looks like a nail. And I've done it too. Like, I don't have any nails. I don't want to go get my screwdriver. I got a screw here. I'm just going to pound that thing in. And it kind of works, sort of. But no, it's better to have more tools. So yeah, here's how I think of it. And it does go back to the prolotherapy because, I mean, none of this stuff existed until 2006, or I shouldn't say that. It became more popular around that time in 2006. When paper came out looking at tennis at that time, and like, oh yeah, man, this is good stuff. But so before that, what we have? We had prolotherapy, and so I had started doing that beforehand. I mean, that's been around since the 50s, and it can work for things. And here's where the strength hierarchy comes in, and I just try and simplify it in my mind. So this is how I do it. So, if you're looking like down here is baseline, below that, oh wait, what's below that? Steroids, they're bad. And I do this with my patients all the time, and I try and beat it into their head. Like, this is bad. This is not good. It's below baseline. So stronger than that is dextrose or prolotherapy. There's other proliferants you can use, but dextrose is a common one. Stronger than that is PRP. About equivalent to that, and we'll have to come back to this one, are all the allogeneic products. So, amniotic fluid, placenta, et cetera, et cetera. But stronger than those things is bone marrow. There's a lot of stem cells in there, and 10 to 100 times stronger than that are adipose sites, the adipose stem cells, because they just have that many more stem cells in there. And it's all an additive healing response because the way all these things work, from dextrose all the way up to adipose, you put it somewhere. And we used to think that it was magically gonna, to use a word from Calvin and Hobbes, transmogrify into something like an eyeball. Oh wait, it can be an eyeball. No, it can't be an eyeball because these are mesenchymal stem cells, and it can only be anything in the mesenchymal stem cell line, which is muscle, nerve, tendon, cartilage, those kind of things, fat. It can't be an eyeball, it can't be an ear, can't be anything like that. And that was a concern when people started doing this in the beginning, like, oh man, what's going to happen? Well, nothing. And then the other concern is, hey, does this stuff cause cancer? And there's been hundreds and hundreds of thousands of injections now, and it doesn't cause cancer in anywhere. It will increase the growth of these things in here, and that's where people thought, hey, maybe this will cause cancer, but it just doesn't do that. So that's the strength hierarchy. But then you're asking about, the allogeneic products. And Utah's a little bit different now. So a few years ago, Utah changed its laws to say that, hey, you can do some of these allogeneic products now. And so there's starting to be more and more companies come up with these products. And so these are products from around the time of delivery of the baby. So this is not the baby. So it's not embryonic. No babies are hurt. Good. Obviously, ethical concerns with that. Not talking about that. That doesn't work anyway. If you use embryonic cells, which they do in research, and they tried to use some of these clinically in animal models, about 30% increased cancer risk when you do that. And so the way I look at that is that's God going, yeah, I don't think you're going to use that. You're not using my kids for this purpose. But you don't need to. So you can use these other products that are just going to get thrown away. So it's amniotic fluid, amniotic sac, placental tissue. It's like umbilical cord, the blood, the Wharton's jelly, all these things. They have live stem cells when they're fresh. And again, I'm thinking hierarchy is about PRP in here. People may disagree with me on that, but that's how I think about it. And by the time they are processed, tested for infection, frozen to -80, transported to us, we thaw them out, we put them in a patient. How many stem cells are left in that, you think, dear Greg?
Percentage-wise?
Give me any.
Yeah. By the time you do all this is great. It's embarrassing. I've never thought about this.
That's okay. You don't have to answer it.
Because it's probably close to zero.
Yeah, it's pretty much zero is what it is. I know this because we've taken these products and sent them away to independent labs and looking at the literature on this too. The companies who make these things don't tell us that, though. They say, hey, we got this great stem cell product. And so if people are thinking about looking at these things, one of the things you want to know is, well, what stem cell, where does it come from? And what are the stem cell counts on these things would be good questions to ask and find out. I have a podcast on this that goes into way more detail. It's about the snake oil salesman. Now, it doesn't mean I don't want people to call you up and call me up and say, hey, man, these things are good. It helped me. I've used these products too, and they're good. Like you're saying, it's the Batman tool belt. You got to use it in the right situation. So I do like them. I have used them. I will still use them for the right thing.
Yeah. And I think for the ones, especially if it's coming like lyophilized or if it, yeah. And I think what they may have is they'll have growth factors in there, right? So there's growth factors and some proteins in here. And then even the kind of soup that they put some of these things in, I mean, there's amino acids in there and there's things in there that can also help. But to me, I always tell people, like, look, if you didn't extract it or you didn't hop on a plane and go to another country where they're essentially, I hate using this now. It sounds really bad. It's almost like farm to table, where it's like, hey, there was a very short period of time between extraction and the cryo freezer and you, then you're probably just getting some growth factors.
Yeah.
And
which is okay. Growth factors are good. It's just not stem cells, though. And again, strength hierarchy.
So I still use a fair amount of prolotherapy in clinic because it's inexpensive. It's a good entry level. And from a perspective of if someone's like, hey, it's like minor pain, it's more irritating. It's a little bit, it's beyond some turmeric and rubbing some topical CBD on there.
Yeah.
It's a little bit of ligament laxity in there. We find it to be very effective, but it's not as potent as the other regenerative products, but it's a good starter for a lot of people, especially if they're, everyone's in a different financial position, man. I'd rather be able to do something that can help you than do nothing.
Yeah. No, I would agree with you too. Yeah. Like, for instance, dextrose and knee arthritis. One of the things we do, this is not traditional prolo. This is kind of modified based on what I was telling you about the power washing. So I learned this from my orthopedic colleagues that I've been partners with over the years. And I saw this. So people are helped after they get a knee scope, mostly probably because of the power washing. My colleagues may disagree with me, but they a lot of times do feel better, not all the times. And so I had talked to my hospital system that I was with and convinced them to get this mini scope system that was quite expensive. And what we did, though, is it was a scope, and you could kind of sort of see stuff. It was one of the first ones of these that came out. Now there's different needle scopes, but you could not see as well as you could with a regular normal scope because it was a small one. But what I did find with that is, man, a lot of these people felt better for a period of time. With the power washing and just getting rid of these inflammatory proteins, what we transitioned to is just flushing the knee out with dextrose. And we've been doing that now for years. And I talked to my colleagues about it and like, how do you do that? What do you do? Like, it works so well. A lot of times I'll tell patients, most of the time, not 100% of the time, but by the time you get to the parking lot afterwards, you're going to feel better. And it's not going to last, but at least it's going to get you started. So yeah, starting with something easy and simple, and what they can do is better than nothing.
So one of the biggest frustrations for patients is when they say, hey doc, I've tried PRP and it didn't help. I paid a bunch of money for it. It was kind of painful. Nothing got better. But in your lecture and kind of looking at some of the other podcasts you've been on, you made the very true argument that not all PRP is created equal. So with that being known, what are some of the variables? Like what makes one type of PRP less effective or less kind of strong, if you will, than another?
Right. So I'm going to go back even a step before that, Greg. So like I've had PRP and it didn't work. Well, why didn't it work? PRP is just one of those variables, and there's a lot of variables in that subset. But outside of that PRP subset, you can look at, well, maybe you just needed something stronger. Like, again, go back to the strength hierarchy and looking at some of Hernigo's data. Maybe you needed to have subchondral bone marrow into your knee, and this is just not going to work. So you got to look at that. And well, even before that, so back another step, did I get the diagnosis right? Did I miss something? So we always got to think about that. And, you probably know a bunch of patients, as I do too, who've had their hips replaced and, oh wait, their pain is still there, right? This happens. So you got to get the diagnosis right. And you can have the best procedure, whatever it is, Prolo, PRP, bone marrow replacement, whatever. If you don't have the diagnosis right, you're not going to help your patient. So it starts with that, making sure you got it right. And then, did I get the right strength hierarchy here? So I'll have patients who I think need to have a higher strength level, like a bone marrow subchondral injection, and they opt to go for PRP, and then it just doesn't work afterwards. And even if we did, like we're going to talk about with the PRP, even if we did all of that, maybe that still just wasn't going to be good enough. So starting with that, then you get to the PRP, what you're asking about. And we get that all the time because, hey, doc, I can go to this place and get it for really cheap. How come I should come to you? Because you're not that cheap. Well, this is the answer to that. So all PRP is not created equal. And it goes back to the Batman tool belt, right? You got to have more than one tool in there or you're going to be hitting everything with that hammer. And the hammer's not always the right tool for it. So if the hammer is the right tool for it in PRP, you start with red blood cells. What are red blood cells good for? They're good for carrying oxygen and life, but in terms of regenerative orthopedics, they're not worth anything. So years ago, when we first started doing this in 2007, there were like one or two commercial kits available, and this one from Harvest. And the PRP you got was really like red. There were tons of red blood cells in there. You remember those? Like it was, and we used that for a long time too. And then they started coming up with the quote pure PRP, where there were fewer red cells, and we're like, that's not real PRP. Because we're used to this stuff over here. Oh wait, no, it is real PRP. But right. But we've learned over the years that just red blood cells, you want fewer of those. Like if you can get 0, that would be the best. The problem is you can't get 0 because it has to do with how you process these things. And when you spin them down, you get, if this is the centrifuge tube, if the tube that you put in the centrifuge, and you get the red blood cells go to the bottom because they're heavier. And then depending on how you do this, there's a couple of ways you can spin it. But if you're doing a double spin protocol, you'll get a nice buffy coat layer, which is whitish, and that's where all the platelets are. So it looks very white, and it can be concentrated, but the platelets are not just there. There's some up here and less up here, and there's still some down here where all the red cells are. So if you want to collect or capture 100% of your platelets, you're going to get a bunch of red blood cells and you're going to have a lot of fluid. We don't really want to do that. So you want to concentrate it down here. So you're never getting 100% capture of the platelets. So red blood cells, pretty much everybody agrees they're not good for regenerative purposes. But we're limited by the mechanics of how we do this.
And they hurt. And they hurt.
So if you put them back in,
goodness.
And it can hurt. So the other thing that hurts, though, is white blood cells. So the white blood cells then in this example here too, so you're getting white blood cells in this double spin protocol, or mostly down here. There's some up here, but you get a lot more down here. So if you're trying to capture more of the platelets, you're going to get more of the white blood cells down over here. And sometimes you want that, like if we're putting it into a rotator cuff or a tennis elbow tendon, you kind of want that. If you're putting it into a knee, maybe not so much. But then you get into the different kind of white blood cells in there, and monocytes seem to be important in there for different healing. But in general, and in joints, you don't really want to be putting white blood cells in there. Again, it's the mechanics thing of how you get this as well. Different systems do it different ways. But white blood cells are important. And everybody agrees that platelets are what you want because that's where all the growth factors are. And you want to concentrate. And if you start off with 10 cc's of blood, and there's some systems out there that do that, you're just not going to wind up with that many platelets as compared to 60, 120, 180. Start off with more blood, you're getting more platelets, even if you never capture 100%, which you won't. So yeah, it's not all created equal from just the PRP. And then you get into, like, I think one of your other questions is going to be, so we won't really dive into it though, like, how do you make sure you're all good to go and we're optimizing everything? And this is just one step of many, many, many steps. Like we were starting to talk about earlier, like you want to optimize everything. So from the doctor perspective is like, well, what can I do? Well, I can make sure I get it in the right place too. That's using some kind of guidance. Ultrasound is really good for a lot of these, sometimes fluoroscopy, doing that. And then what are you doing post-injection protocol? Are you having them walk on it right away, or having them lay in bed for a month, somewhere in between? Are you going to physical therapy? What are you doing for your protein? What other supplements are you doing, whether hormones, whether peptides, blah, 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 blah. So there's a lot of things in here that need to be considered when we're doing that and we're looking at the PRP.
Now, and this gives me a good segue into patient selection.
Cool.
And where I'm going with this is because, right now, younger patient, it's like, they got these robust stem cells, and probably platelets are, they're younger, a little fresher, if you will. But as like everything else, as we get older, things change. Is there a kind of like an age cutoff? It's like, hey, you know what? You got this injury, you've got this arthritic condition here. Here's some options that I would like to do, kind of autologous, if you will. But because of your age and maybe even your lifestyle, this isn't best for you. So is there a point where you're just too old to be considering PRP or even bone marrow or adipose stem cells?
I'm going to give you some data from Hernigo to answer that one here. So he was looking at knee arthritis and different treatments for it, which was total knee arthroplasty or doing these bone marrow subchondral injections. And so this subset of patients was patients who were over 80. And this was fascinating when I saw this data, and I just saw this for the first time at a conference in February that he presented at. I'm like, no way, this is so good. I need to tell people about this. So what he did was with 340 patients, he looked at their 10-year survival rates, and just survival, like all-cause mortality, doesn't matter, like who lived the longest. And so when he compared it to the general population, the ones that did not live the longest were the ones that had 2 knee replacements. Only slightly better than that were people who were on anti-inflammatory drugs, NSAIDs, ibuprofen, Aleve, those kind of things, and had steroid injections. Are you kidding me? Wait a second. So knee replacement was the worst. Just only slightly better were people who took pills or had shots in their knees. No, they just didn't live that long. and you followed them out for these 10 years. The ones that lived the longest were ones who had these bone marrow injections into the bone. Much, much better survival rate compared to the general population, and much, much, much better compared to people who had knee replacement. So that answers my question on the older part. So my answer is, okay, well, what other option do you have? Like, you can't give them NSAIDs, can't do those big procedures on them. This is better. It's been proven to be better. And then you can answer like younger too. And is there a lower age limit of this? I mean, you're not doing this on 3-year-olds, right? But I've had 12-year-old dancers come in here who've had various problems that needed something done. I'm like, yeah, we can do this on you. The big problem there, though, is if you get that age group, are the parents pushing them to do this, which is why they're injured in the first place. And that's a hard one to decipher out, because you got to get the kid alone to see if they really want to be doing this or not, because you might not even need to do these treatments on them if you just get them a rest.
Mm-hmm. Yeah, I mean, as a former young person, I'm probably not gonna opt for the needle in my knee, So,
well, they don't like it either, too. That's the thing.
I've
tried this on people, and yeah, it's not a big positive in their lives, right?
Mm-hmm. No, I get it. Be the same way for some older people too. They're like, nope, not happening. Not happening. So,
well, and that's why we bring an anesthesiologist in now for a lot of these things if they want it, and that wasn't available back in the day. And now I've found that the recovery is so much better if somebody's not anxious when they're having the procedure done. And if we're doing bone marrow on people, nobody likes that, right? I don't even have this on my website. I don't want people seeing it.
Oh yeah. It's not pretty. I had it done on my knee when I was in med school, and I was kind of a test patient, if you will, because the resident was learning, and I was like, hey, this is fine. Okay. I mean, I got it for the price, man. It was right up my alley for a student, so
free,
basically free. Essentially, I was paying for the consultation, and it was an interesting kind of like, okay. The thing is, I was very numb. So thankfully, I just heard the tapping, I felt the pressure and all that stuff. So it got very sore when that wore off, but at the same time, I think the healing was great, and it was actually a pretty cool thing to do. And I actually did some training. I never really got into it. I actually went down to a place down in Florida, and I learned how to do the adipose extraction and the bone marrow extraction. And I was like, I just didn't feel, there's places that are doing it and not in the most sterile facility. This is not something you want to do just in your basic treatment room, right? And I was like, we're not set up for that. And time went on, and I was like, hey, if this is something you need, I have great referral sources for you, but it's just something that I'm just not doing.
So you're saying you're not going to do this in your garage? Is that what you're saying?
Oh, Greg? Man, yeah. I was like, in the kitchen. It's like, come back here in the break room. Got you. Just you won't feel a thing. So I want to circle back to the clinics. You mentioned there are clinics out there, more of that, for lack of a better term, the snake oil thing, where not being exactly transparent in what they're offering patients. Because and there's a lot of places, hopefully a lot of these places have been kind of weeded out because people are smarter now, and there are the FDA, I believe, is really kind of sending pretty nasty warning letters to a lot of these places when they offer it, but they're still out there. So if a patient is like, hey, you know what, I went to this clinic, they offered me a stem cell injection, but they didn't say anything about bone marrow, adipose, or even, hey, go to another country to do it. What are some of the questions these patients should ask that clinic if they're being offered stem cell injections to make sure they're getting the real thing?
Yeah, no, that's really good point, because as a patient too, right? I'm a patient. I mean, you just don't want to be, you want to have all the information, and you don't want to be led down a path that you don't want to go down, right? And you would hope that people have the best ulterior motives in business, whatever you are, like your practice, my practice, their practice. So I'll assume that they have the best motives to start with, which may not be true, but assuming they do, one of the things you want to ask them is, okay, well, what are you using? So that's the first thing. What stem cells do you have? Where are you getting these things from? Is it from you, not you? That's the first question. So autologous, allogeneic. And if it's from not you, then where is it coming from? So is it amniotic? Is it umbilical? What is it? And then the other thing I would ask for, and I've done this, I just have not been successful in receiving the data from these places, like the companies that make these. And I know some of the people involved in this space, so it doesn't mean they're bad and they're evil. I think they're doing a good job. You just got to know what you're getting. So like, okay, well, how many stem cells do you get from this? And they won't have huge quantities of data, but they'll have their sample, and they should be able to give you something like, oh, in these 5 samples, 10 samples, this was the average and this was the range. All right, that's good. So give me some of that info. So that's the stuff. And then next you get into who's doing it. So what's their background? Like you're saying, are you going in the back room, in the break room and doing this stuff? Or where are you doing it? Where are you doing this thing? We have a procedure room that we set up just for this. So it's not just a regular exam room. I mean, we bring the anesthesiologist into there, and he brings all his anesthesia cart in there as well. And we have our ultrasound machine in there. So you can fit all these things in there. And it's not an OR, but it is a procedure room. And so then that's who's doing it. And then guidance is the other important question. How are you making sure the needle gets in there? What you don't want to hear is this. Oh yeah, it's, we're going in your right shoulder, but doc, it's my knee that hurts. It knows where to go. It's going to get there. Okay, that's kind of a bad example. And hopefully you would figure that out. But, right. The shoulder, you're like, okay, well, how do you know you're getting into the right spot? Well, you need to get it there somehow. Ultrasound is, as you know, is a great tool for looking at soft tissue. It's not so good for looking at bone. So for that, if you are looking at bony kind of things, maybe fluoroscopy is good. But I found you can use ultrasound for almost everything you need to look at and get it there. And that requires training to do that. So you got to know how to use this tool. And it's an expensive tool, right? Like, you have these expensive pieces of equipment and you got to learn how to use them. And it's great when you do learn how to use them, though, because you can help a ton of people that way. Those are some of the questions. Just ask them, and and then there's just the gestalt feeling too. Like, do I get the EBGBs when I'm there? Do I feel like I need
something just isn't right?
Or like, do they make me feel good about it too?
Yeah,
don't use just that, but yeah.
Well, it's good, and I'm so big on not forcing things, it's just like, and it's being able to read people. So if I'm discussing it and there's a little bit of hesitancy, it's like, hey, you know what? I don't want you, you do not have to make a decision today.
Yeah.
And maybe while you're thinking it over, we can talk about some dietary changes, some supplements, some things to do. And we'll talk about peptides and lifestyle and things like that. And say, hey, let's give this a little bit of time. And if it's not moving the needle, let's re-engage with that conversation. Yeah. Because I think that there is something, I never want to come off as like, say, like, it's that whole, how it is when you try to buy a car and you're just like, you're like, I got to let me think about it. And they're just kind of like, oh, well, you know what? This might be gone, man. The price will go up next night. You have that feeling that you're being pressured, right?
Yeah.
And that's something I never want. I'm very quick to walk just like, let's not.
Yeah.
I would not want to be treated that way either.
No, nobody likes that. And I remember going to used car places and feeling like that too. Like, no, we don't want to do that. We're helping people. We want to help people, right? Yeah. That's why we got into this business. I want to present options for them. Like, oh yeah, I really don't think you should do this for these reasons, but it's up to you. I'll tell people, you're the CEO of your healthcare. You get to decide. You make all the decisions. I'm just your advisor. Tell you this is what I think, but you need to do your own research on this. And we have a lot of people that don't decide that day, and they decide to think about it or to come back. And we also do kind of like you were talking about, okay, well, if you don't want to do this thing, how about we do this and optimize these other things in your life? And I think it'll help you, but might not be good enough, but I think it can help.
Yeah, and you get them started. And that is an excellent segue, because one of the things that you discussed at the presentation I saw was this concept of Wolverine healing.
Yeah.
And so what are some of those basic standard, if you will, lifestyle recommendations that you discuss to start the healing pathway with your patients?
Yeah, I like this too. And I know this is what you do because looked at your website and saw and we chatted, but this is so good. And first of all, I wasn't taught any of this in med school or residency or fellowship either, like none, zero. And it's the principle of optimization. That's what it is. So it's just optimizing the whole body. And there's various ways to do that, right? It starts with nutrition and anti-inflammatory diet. It starts with being hydrated. Oh, wait, sleep. Sleep is so important. And, I've read Matt Walker's book, Why We Sleep, and you hear Peter Attia talk about it. But you know what? It's so true that, oh, wait, we have human growth hormone pulses through the nighttime, and we have more of those. You're going to get more healing going on. So those are the three things that patients can control, but it's the hardest for them too, right? Because it requires habit changes and they just want a pill, including me. I'd take a pill if it was going to make me the Wolverine. Shoot, give me that pill. I'm in. But it doesn't work that way, unfortunately. So you got to put some effort in to yourself. So starts with those things that you can control. And then we talk about supplements. And the ones that we usually talk about, vitamin D with vitamin K, vitamin C, melatonin to help with sleep. Again, you get into the deeper phases of sleep, you get more healing. Collagen peptides, creatine nowadays too. That's really important. Getting just enough protein in your diet for healing purposes. And it's not what the US RDA is. So that's like 0.8 milligrams per kilogram. Even if you're going up to 1.2 milligrams per kilogram, it's just not enough. You need to be up around 1.6 or 2 milligrams per kilogram. Or the way I'll tell patients, because it's easy to remember for them and me, like a gram per pound of body weight. Because then we have to, if we're doing kilograms, you got to translate. Nobody knows how to do that. But so a gram of protein per body weight per day. That's a lot of protein, right, Greg? I mean, I have a hard time getting that for me, and I'm pretty into this. And the only way to do that is you got to supplement with shakes or whatever else too. So then you get into bioidentical hormones, and that's so cool. I really like this. Again, taught none of this stuff. And that World Link conference was all about this. That's where I learned it from Neil Rouzier over there years ago. And I started, this was interesting. This was my journey. So, first I had some friends who do these regen procedures, 2 of them in particular, and they went to that course and go, hey man, you got to look at this because our patients are just doing so much better when we optimize them on these hormones. And then my wife was going through menopause at the time, and she started on some bioidentical hormones. Like, why are you doing that crap? Like, that's because this is what I was taught, right? Like, stop that. That's no good. But it makes me feel so good. Like, I don't have all my symptoms, and I feel like I have energy. I'm like, okay, I need to look into this. So went to those conferences, and what they're like. It's 2.5 days of just looking at data, and Neil goes through it, and now other instructors are doing that. But you're going through the data, and it's proven to me that this stuff is good. This works. It works for tons of different things, for decreasing cardiovascular risk, increasing your lean muscle mass, decreasing your fat. A typical one I have for us is, right, we do regen ortho stuff. We do bioidentical hormones, of course, but it's usually in conjunction with my knee hurts doc. But so many women come in here, my knee hurts doc. We look at it, I get arthritis, meniscal tear. And then we're just chatting and they're talking about, I had these levels done. My doctor said they were good, but I'm so tired in the afternoon. Like, it's the classic thing. And you just give them some T3, and we do other things too, but just the T3 part of this can help them so much. And it's almost like magic. Like, oh man, why was I not taught any of this stuff by our blue pill medical model? None. Like, I wasn't taught any of this. You probably were, though, because of your background, but not me. I wasn't taught this.
Oh, it's interesting when we talk about hormones and some of these things when it comes to setting a foundation. And one of the things, and I'll kind of give you a really, really quick background with how I that was my kind of postgraduate training that's all I wanted to do, man. I wanted to do orthopedic injections. That was all I went in for it. So yep, I just want to pop and go, man. I just want to come in, get the needles in there and get out of here, right off in the sunset as a hero with my injections, right? And I started off like that, and it was starting to gain some traction. And then COVID happened. And that pretty much was the brakes on that, because obviously less people are getting outside and doing the things, unfortunately, that get them to you, because no one is falling off their skateboard, things like that. And again, that that's the only reason we saw people, but there was a little bit less, a little more sedentary behavior. You're getting less of that. But one thing I realized is that when I was in that kind of, what am I going to do next? How do I pivot my practice and who I'm going to be as a physician? I had two big categories of people, man, that I thought about. And one was, you had these people who, hey, doc, my knee hurts. Oh, by the way, I'm overweight. Oh, by the way, my diet is crappy. Oh, by the way, I drink 10 to 15 drinks a week. And I would inject these people, and it was like basically bouncing a rubber ball off a wall. It's like it didn't do anything.
Yeah.
And then I would have these people, it's like, man, I'm healthy. They were the opposite. Yeah. And you inject them once and you may not see them ever again, not because they hate you, because they're just doing so well. They do their follow-up. Thanks, man. I appreciate you. If anyone else gets hurt in my family, I'll have them send it to you. And that was my light bulb moment of like, okay, I'm doing this backwards. Like, I'm reaching for my needle. Like you said, everything looks like a nail, when I need to really be getting the foundation either before or in series with what I'm doing.
Oh, yeah.
And that was the light bulb. And game changer, man.
Yeah.
Game changer.
I totally agree with you. And that, again, I started off like you too. I like sticking needles in people. It's fun, and then you can help them, but you're not helping them if they're not getting better, right? And it's all those things. It comes back to optimizing. It always does. And I got so many examples, as you do too. Like, they'll come in for we'll pick on one of my friends' wives. So she had back pain, younger woman. And she was overweight. She had a bunch of babies, and she had gained some weight and never lost it. And she had the back pain. And we talked about different things. I'm like, why don't we just focus on losing some weight now, right? He could never say that to her, but I could, because I'm the doctor. Like, and I would be at parties with her. I'm like, I can't really tell her that there, but because I knew what was going on. But she came into my office, and now I got permission to talk to her like this. I'm like, yeah, let's do that. I mean, let's try and get some of this weight off you. And you know what? She lost the weight, and her back pain went away. She didn't need to do anything else just because she lost the weight. So yeah, you got to optimize everything. And I agree, first is better. Like, if somebody needs to lose 50 pounds and we're talking about knee injections, it's definitely better to get some of that weight off first, because for every pound of weight on the belly, that's 4 pounds of pressure on the knee. So you can really make a difference with even 10 pounds and the pressure on the knee. And maybe you don't need to do these injections, or then the injections will work better if you do them.
Yep. Yeah, I've had a few incidents, man, where I was like, dang it, I did this too well. I have worked my way out of an injection.
Well, see, that actually is the problem from the business model perspective of our jobs. Like, not so good. Got to be less good at our jobs. But with arthritis, actually, that's a good segue for this one. With arthritis, like I said, you're not curing arthritis. We don't know how to do that at this point, but we can manage it. And what'll happen is, say we do whatever injection we're doing and it works. People are doing great. At some point in time, it's going to start to come back, and they're going to call you back up and say, hey, doc, my knee is hurting me again. And that point in time is somewhere after a year, usually. And then what we recommend doing is, I call it the oil change, because it's regular maintenance. Just dextrose lavage, flushing the knee out with the sugar water, followed up by a PRP. And just that keeps them really good for years and years and years, if you just stay on that schedule. And, people are people, and they won't do that. And then they won't do it for 2 years or 3 years. And they'll call me, hey, man, my knee's hurting me again. And I'll look back. Last time you had this was 3 years ago. You need to come in and do this. The problem is, if you wait too long, now we got to do a bigger procedure with the stem cells, the fat, the bone marrow, those kind of things. Cost more money. It's more recovery. Like, you don't want to do that. So come in for the oil change. It's easier. And I have... Oh, go ahead.
Oh, no, go ahead. Go ahead.
The last part of this story is, and I had Fast Eddie was in my lecture there for World League. So this one guy, Fast Eddie, if you're listening, I love you, brother. You're awesome. So he's such a nice guy. And what we did was we did a bone marrow fat procedure. He had both knees with arthritis. And we did that in 2009 around Thanksgiving. And I know that because every Thanksgiving he would text me and say, "Hey, doc, thanks, man. My knees are doing great." And every year I'm wondering when he's going to tell me, "Hey, doc, thanks. My knees are not doing so great anymore." And so we did this in 2009. And just this year in 2025, he texted me back and said, "My knees are not doing so great anymore." I'm like, I was wondering when you're going to get in touch with me. This is like amazing. So I know it can last for that long, but it usually doesn't last that long. For everyone out there listening, 1 year is what we recommend.
And there was a study, one of the doctors at the conference I just came back from that was mentioning, and he was talking about how it's becoming more evident that if someone is going to do something like a PRP, we'll use PRP as an example, is that you need to plan to do a series of 2 to 4, 3 to 5, somewhere in there, because when someone goes in and they get a Synvis injection, a hyaluronic acid injection, they're already letting you know, like, this is a series. Yeah. You are going to need 3 of these.
Yeah.
And when they start doing head-to-head on the response between that, doing the 3 hyaluronic acids, and it's like, oh, let's do 1 PRP, let's match the PRP to the hyaluronic acid injections, they were seeing the outcomes were significantly better doing them as a series.
Yeah, there's a bunch of different studies on that. That's a good point too, though. Basically, what that comes down to, Greg, is looking at the platelet dose that you're getting in the knee. And so if you're doing 3 of them, you're getting a higher platelet dose. Remember, it starts with how much blood volume you're getting and then how much platelets you're getting from there. There's no way with a 10 cc volume, you're going to get the same platelets as 120 cc's. You're just going to get more, no matter what system you're using to collect it. So yeah, whether you get it in 1 or a series of 2 or 3, that's what seems to matter. And, I just came back from, in February, this other conference, they were talking a lot about that, like a whole day of just what you're talking about now. So more platelets equals better outcome. 10 to 20 billion for knee arthritis seems to be the answer.
Okay. Gotcha. All right. And so you mentioned something else I want to make sure we touch on, and that is testosterone.
Oh, yeah.
Because, for me, it was like, we first started learning about testosterone. It's like, yep, we're asking questions about energy and libido and erectile, and this for guys, erectile function and brain cognition, brain fog, all these amazing things, and mood. And then one of the big things is like, oh, what about joint pain? You're like, oh, joint pain, it's getting better. And for the longest, I just accepted blindly, like, oh, this is great, because again, people are getting less pain, but okay, but why? Right. And then I start pulling the string. It turns out that testosterone not only has an anti-inflammatory component to it, but some of the studies I looked at mentioned that it can actually increase the production of collagen and actually reduce some of the chondrocytic pathways. And I was like, oh my God, this is amazing, right? So circling back to something you said earlier, if someone is a candidate for regenerative injections for whether it be PRP or stem cell, even prolotherapy, and they have low testosterone, are they really fighting an uphill battle?
Short answer, yes, absolutely. So that's one of the things we talk about with our guys all the time. And you get this too. Hey, I had my testosterone checked, but I have erectile dysfunction symptoms, I'm fatigued. But my doctor checked it and said it was normal. So here you have a guy with, quote, normal testosterone, but is symptomatic. And what I was taught in my blue pill medicine model, sick medicine, blue pill, traditional model is, yeah, you're fine. You're normal. Go away. Don't bother me, kid. So, but that's so not true. That's why you're bringing this up, obviously. You, first of all, are going to do so much better with your knee arthritis if your testosterone level is optimal. And so I'm going to go back even steps too, because you look at it and this, but just for everybody out there, who's listening and is not familiar with how these labs are obtained and the normal levels are obtained. If you pick on thyroid, normal levels are like this all throughout their life. It's stable. What they do with testosterone is normal as this, and it comes down like this with age. So why is that normal? It is the only lab test that is like that. Well, estradiol is a little bit different for women because it has to do with their cycle, but that goes down like this. So testosterone, that's just not normal or optimal is the better word. So it might quote be normal, but it is not optimal. And then even if you're up on the high end of the range of the level for your age, if you're 50, that doesn't equal a 30-year-old guy level. So what we try and do is we shoot for 30-year-old guy levels, not Arnie Schwarzenegger levels way up there. That's clearly not good either. Too low, too high is not good, but shooting for 30-year-old guy levels, and you're going to do better with everything. Oh, wait, you know this data too, but cardiovascular risk is going to go down because you're optimal in your testosterone levels for men and women. And, your women are probably like this, your women patients, some of them will give me the look when I first bring it up and they're not well versed in this at all. And I'll bring up, yeah, we even do testosterone. And they look at me like, yeah, I don't want to start shaving. No, it's woman levels. We're not going to make you look like Greg, and you're not going to have to shave your beard. You're not going to have to do that. So,
so even though sometimes it can grow some facial hair, it's at the end of the day, you want to just, everyone's, what's interesting with that is that I've had some women whose levels are on the lower end and they'll start getting some hirsutism. And then I've got some that, will get their testosterone. They feel better 200 and above, and they not a single whisker. Yeah. And it's all about the androgen receptors. And so everyone's a little bit different. So I think managing that, but a full beard is a little bit aggressive. So we have to be mindful of that.
But I have some women like you're bringing up. So there's the individual responses to the level of testosterone, and then the individual women may want more. So for instance, I have some patients that want some of the libido effects of it. And like, yeah, I want more. I'm okay if I have to go laser my hair off. I'm all right with it. And other ones are like, yeah, I never want to do that ever. So yeah, it's talking to your patient. It's the art of medicine there, figuring out what they want. It's not what I want. It's what they want.
Very true. So we've done some good talking on these are things to bring in, but I want to spend a little bit of time on things to avoid. And from your lectures and getting back through some of the slides I saw, there are two things that you're really firm on: corticosteroids and statins. Now, from you was talking earlier, and it's no secret that steroids are bad for cartilage. And I think they're also bad because they're so great at masking pain that a person can get a steroid injection. Oh, my knee feels great. I'm back to running. I'm back to jumping. The steroid injection wears off. It's like, oh God, this hurts way worse than it did before. That's no surprise there. And there's a reason why even traditional medicine, they starting to slow down on the amount and the frequency of steroid injections, but they're still doing them and it's still a fallback.
Yep.
No surprise there. But the big surprise for me, and maybe for a lot of people, is the warning against cholesterol medications and statins. So for those who are not versed in this or learning this for the first time, how do statins impact muscle and tendon health?
Yeah, statins they're ubiquitous, right? I remember in my residency too, one of the cardiology attendants said, "Oh man, they're so good. I just think they need to be in the water." And that's kind of our blue pill medicine, traditional medicine thought on these things. And in the WorldLink conferences, you go through the data on these things and you're looking at this, and they are really good for a couple things. So we'll start with that. So they are really good for lowering cholesterol. I mean, you just look at it. People are on statins, their cholesterol is lower. But what are you really trying to achieve with that? You're really trying to achieve cardiovascular protection, decreased risk of stroke and heart attack and dementia and things like that. So that's what you're trying to get to. And there's just no good data on primary prevention for that. There is good secondary prevention data. You've had a heart attack and preventing a second one. So that's really good, that data. But what are the side effects? At what cost do you get this stuff for the secondary prevention? Or if we're using it for primary prevention, oh wait, it's not achieving, or at least we can't prove that it's achieving what we want it to achieve. So everybody knows about the risk of myopathy, and it's reported in the literature between like 1.5% to 10%. But I think it's way underestimated. And in clinical practice, we just see that a lot more. And then also it has a significant negative effect on tendons as well. So giving you for instance, me. So Genetically, I have high cholesterol, and I think I eat pretty well, anti-inflammatory diet, not perfect, but pretty darn well. And I exercise a lot. So I don't think I can really change any of those two things significantly. So years ago, I went on a statin, put myself on a statin, and I was doing ultra marathons at the time, and I wound up tearing my Achilles tendon. And I couldn't run for 3 years after that, even doing some of the regenerative things that we do and stopping the statin. Still took me years to recover from that. And so that's just an example. It doesn't mean if you're on a statin, that's going to happen. But I see tons of patients in here who are on statins and have all these tendon problems too. So there is a correlation with tendon problems. And it's so, the statins are, they affect our bodies to a level down to the mitochondria. So it gets way deep down in there. And the more you take, the higher dosage, the worse this is. And then at this WorldLink conference, I was just reminded too that, oh, wait, now you have a risk for diabetes as well. So you have a risk for diabetes, all these musculoskeletal things. And so for the musculoskeletal aspects, I'm looking at me. I am never going back on these things again because I don't want to not be physically active and do the things I want to do. And oh, wait, there's other ways to achieve the same results, I think. And you don't have to be on a statin to do that. And that's testosterone is one of them. Fish oil is another one. And in Peter Attia's book, he does a great job of bringing out exercise as medicine and how just the effect of exercise is more than the effect of a statin. So we don't have to be on these statins, even though we're given the blue pill left and right.
Yeah, that's like one of my life's missions is try to get as many people off statins as I can. And it's just, I've only had a couple of patients, but they were true, no kidding, FH or familial hypercholesterolemia. It was like, and we did all the things. And it's like, we had to kind of make that decision, but we kept it extremely low, and just like to manage it. And then, it was tough, man. And it's one patient we were trying so hard, man. I kept lowering. And I finally like, okay, we're going to stop it. And it just shot up. I was like, oh, goodness, I felt horrible, man. I was like, it works so hard. We're so close.
Dang it.
But there'll always be those, but then we do all the things to manage it. We keep them on CoQ10. We're doing a lot of the things. We're doing a lot of liver detox support. We're really working on mitochondria. They're all on mitochondrial support too. Those very reasons. So it's kind of a challenge, but I get it. So before I let you get out of here, man, it's like I can never leave any conversation in my life these days without talking about peptides. I can't. It's just, it's who I am as a person now, right? And so as they are becoming a massive part of regenerative medicine, and we were talking before the show, so you've started your peptide journey.
Yeah. So here's how it worked for me. Again, been more traditional medicine minded in my training, but I had to break out of that. And one of the things, like we're talking about, our patients teach us these things. So I had so many patients, as you probably have too, that have gotten peptides online and they're like, hey doc, I started this one and I'm doing this. I'm like, it's great now. I've had these good benefits from it. And I'm like, okay, I've had so many people tell me that I had to actually start to learn about it. And I remember the first time I heard about them at a conference was probably right around the time when you started, like 2019 or so, doing injections and things. I'm like, okay. I heard in a lecture and they were going through all these peptides and I was like, brain's on fire. I can't comprehend all this stuff. Like there's too many of them and there's too many indications and you're not making it easy for me. I can't do it. So that's the first time, but then it's become more, I've wanted to learn more about it. Let's put it that way since that time based on input from my patients. So then I have. So this year I started learning more about peptides and you came to this conclusion before me. I'm like, oh my goodness, these things are so good for lots of things, but you do have to learn about what's good for what purpose, because there are so many and how do you do it and that kind of thing. And there's different protocols out there. But in general, here's how I put it into my Wolverine mix. And it's in my Batman tool belt that it's another thing we can do to help people and just help them to be healthy, optimize their health and to heal some things. Now, if something is broken this much and like you have a tendon that's this far apart, it's not going to heal that. but it's going to help with it. I think, it's the next step beyond the testosterone is how I'm putting it in my mind.
No, they could be game changers, man. And peptides are kind of my jam, lack of a better term. And what I've realized is that for anyone who I'm considering doing a regenerative injection on, and the protocol is going to be different for the person. So I don't have like a standard, you're going to be on these 4 things, these 3 things. It's really going to be based on their level of pain, how it's affecting their life, and how it's affecting their function, right? But if we have that conversation and it's like, hey, we're planning on doing a regen injection, you got travel coming up, we can't get you in for this to another maybe 3-4 weeks. I definitely want you to start some peptides to really help minimize the pain until we get you into treatment, but also because it's going to start the healing process that the body needs. But on the back end of it, after the injection, it's going to only accelerate the healing process that the regenerative injections are doing. So we're able to use them on a before and after phase. And what we're seeing is the outcomes are tremendously better. Tremendously,
Give me an example of that one, because you've been doing that for a while now. Give me an example.
Life. So my, so BPC 157, and I always say BPC 157 has been worse for my regenerative injection business. It's the worst thing ever happened to my needles, right? And for that one, we have this Wolverine stack has been the whole thing. We used to always call it BPC the 157 BPC 157 the Wolverine peptide, because it just helps heal so well. And so I'll give you the 10,000 foot view. And obviously BPC 157 is this 15 amino acid peptide that we make in our gut, and that's great. But it has, for a healing broad spectrum thing, I like BPC 157 because it's anti-inflammatory, it's analgesic, it's going to help with some type 1 collagen production. It's this whole Faxpaxilin pathway that we won't bore people to sleep with going, right now, but helping the body start the process of regenerating cartilage and sort of tendon and ligaments, right? And so just regenerative when it comes to those type of injury conditions, and also reducing those inflammatory cytokines. So it's really starting all these healing pathways going. But when it comes to, now when you mentioned about protocols, now there's different protocols for different things. And so if it's a situation where it's either acute injury, severe injury, post-surgical, we're dosing it higher. And the rule of thumb I kind of have for peptides is slow and low. But after an injury, after a procedure, we're going fast and high. Like, I really want to start pushing those pathways a little bit further, not for a long period of time. We're talking 10 to 14 days. So that's kind of my top one. And then there's thymosin beta 4. And then you'll see TB500, depending on the source you're going. The end of the day, thymosin beta 4 is the full amino acid thing. So it's kind of like you're getting the entire, it's like the entire DVD box set for the kids out there that don't know what DVDs are. The way we used to watch movies back in the day. It's like, here's the whole box set, where TB500, and here's a couple episodes you might like. And those episodes can be pretty good because it's the part of the molecule, part of the peptide that's doing some of the cell migration things and helping with healing. But TV4, and I want to bring this back to BPC 157, is the angiogenesis piece, right? They both upregulate VEGF, or vascular endothelial growth factor, and that's helping your body getting more vasodilation and getting more healing molecules to the site of the injury, because most of those injury sites, as you know, like your tendons, ligaments, they're pretty avascular. You need blood to get there to heal. And so it's doing that. And this is where I have this, I get into these borderline, I'm getting nicer on my social media, man. I used to get into these little mini arguments with people like, oh, it's going to cause cancer, angiogenesis. I'm like, what are you talking about? Like, what? Because of the VEGF? You mean the same growth factor that gets upregulated when you work out and when you heal a wound? So if that's the case, stop working out, because that's causing angiogenesis too. Don't get me started, Joe. So, so those are kind of my top 2. But the last one that I really love, sorry, man, you open Pandora's box.
Go, man, go.
The last one I really like for healing is GHK copper. Now, GHK copper, this tripeptide, we really think about it for aesthetic purposes, and it's amazing for that, right? Because it does increase, the production of collagen and elastin, and these are great for skin health. And it also helps with hair follicles. But GHK copper is also anti-inflammatory. It's also reducing oxidative stress, and also helps with the angiogenesis process as well. So it's also great for healing, not just that skin and beauty thing, right? So those are like I would say top 3, but I'll put three, I'll say top four, because I also want to include the growth hormone releasing peptides, because growth hormone is a healing peptide.
Yeah.
And so, or is a healing hormone. And so anyone that's trying to heal, I also want to make sure the growth hormone is optimized. And sometimes it may not be a matter of, here, take this peptide, you need to sleep, right? Because you mentioned the growth hormone pulses when you sleep. And so, and there's other ways to do it. Obviously, if someone's in pain, I can't say, go out there and power lift, young man, because I need you to upregulate your natural growth hormone. But that's also essential. But if you can, you can start reducing the inflammation, reducing the oxidative stress, improving blood flow to the site of injury, and upregulating your healing anabolic hormones, and growth hormone is one of the anabolic ones, that just sets you on this path of healing. And so the key where the art form comes in, it's the same as injections, man. The art is which peptides do you need at this time, how long we're going to cycle it. And that's where you mentioned kind of people buying these things online. That's where I'm like, all right, well, that's cool. Like, you can, just because you can do something doesn't mean you should, because how are you dosing it? How are you using it? And also many of these online peptide companies, I mean, they're really not doing the necessary testing to protect the person on the end user.
Right.
So yeah, man, that's kind of the peptide story. I'm sorry, Joe, man.
That's good. Well,
you're like, who's the guest and who's the host here?
No, this is good. It's good to know. And I had a guy come in the other day, and he was a really muscular guy, taller guy too, and he was into powerlifting, and had him fill out our intake form of what medications he's taking. Is like nothing, right? Like, come on. So I asked him, I go, what are you really taking? He finally fessed up and told me that he's getting all these peptides, and he's on. I'm like, where are you getting them from? And who's managing them? My coach. My coach is doing that. I'm like, okay, well, yeah. So who knows where you're getting them? Quality is kind of an issue with that, right? And then he's using them totally different than you and I are talking about using them. That's like Arnie Schwarzenegger levels for that. That's not this.
Oh yeah, it's different. It's the Wild West on many levels out there, man. And I always tell people, like, the patients who want to work with a physician, who want to kind of, I don't want to use the term the right way, maybe the safer way. Maybe they're like, look, I'm not an expert in this. It's kind of like, I could and this is the analogy I'm working on this analogy, Joe. I got to figure out how to really, I'm trying to perfect it. It's like, hey, if I was getting sued, I can technically defend myself in court. I have the right to defend myself, right? But it's probably a really bad idea because I didn't go to law school, right? And I don't know the law completely, and I'm probably going to lose the case. And I don't understand how this is the equivalent of that. Like, you're literally defending your own case without a legal degree. And not saying you have to do that. There's some smart people that do that.
Yeah.
But at the same time, if I'm really trying to get the best advice, the best service, the best kind of opportunities to win the case, I'm going to work with an attorney. This is the equivalent of that. Like, hey, you know what? You can defend yourself in court, but at the same time, if you want to work with someone who has been trained in peptides, who understands the pathways, understands the protocols, then you want to work with the physician just like you would work with an attorney. So that's kind of my.
That's a good analogy.
I got to work on it. Yeah, I got to work on that one. It needs some work. But we'll get there.
Good.
No, and so this has been great, man. I really appreciate your time. Kind of hanging out with me here. Late into the evening, if you will.
Appreciate it.
For the person listening at home, maybe taking ibuprofen or an NSAID, or they've been told they need a steroid injection, or they recently had one, what's the first red pill step that you would recommend they take today to take control of either their joint health or their pain?
If I have to pick one, I'm going to say anti-inflammatory. Get rid of sugars in your diet. So again, this is the hardest one though, but to get the most bang for your buck, I think that's what it is. So again, not a popular way of, or popular thing to say, but getting rid of alcohol. And it doesn't mean forever too, but it does mean for some period of time. So alcohol, sugars in the diet. So if you're drinking sodas, that should not be there. Those are not good for anything. Especially just inflames your whole body. So getting rid of the sugars. So carbohydrates, good carbohydrates too, pastas, rice, potatoes, things like that. But if you just did that one step, it would go a long way to helping your body feel better. And it won't happen right away, because first you're going to feel bad because you're stopping this thing that you are literally addicted to. But after a period of time, week, 2 weeks plus, then you're going to start feeling better. So diet, meaning not less food, but eating the right food. It could mean less food too, but that's not what I'm talking about. I'm talking about just getting the right food in there.
For sure.
All right. That's the one, man.
That's a good one.
Yeah.
That's a good one. All right, man. And last but not least, for those listening at home that want to learn more about your work, where is the best place for them to find you online or connect with your clinic?
Yeah, thanks. It is albanoclinic.com, ALB as in Bravo, ANO clinic.com. Phone number is 385-220-9009. 385-220-9009. But if you go on our website, we have a lot of information on there about all these different kind of topics, regenerative wise, and different body parts and PRP and that kind of stuff. And so it'll give you an idea. We also have, YouTube and Instagram. And shoot, I don't have that right here in front of me, what those are too. But if you look me up, you can find it.
All right. And we'll find those. We'll put them in the show notes too, so you don't have to worry about that. We'll make sure we connect with your YouTube and your Instagram and the clinic's website and all that good stuff. Hey, man, I want to say thank you again. This has been a pleasure. Always great talking to a fellow veteran, and also someone who also has found the love of the needle, which is I like to. That might be the title of my first book. A love affair with needles.
Love of the needle, but it's more than that. I mean, it did start with that for both of us, but it's about the whole body. It's about the whole person.
It really is.
That is awesome. I love it. So thanks for having me here, Greg. Appreciate it again.
Thank you. I appreciate it. All right, everyone. It has been another episode of the Dr. Greg Jones Optimization Academy podcast. Again, the notes for Dr. Albano, where to find him, where to learn more about his clinic, will be there for you. I want to thank you all for listening. And until next time, let's stay optimized.